And it's my great pleasure to introduce George Mavrogenis. He is from Greece, an ESD and third space expert, and we're already working together for many years. Usually I call him Mr. YouTube because whatever video on a procedure you would like to find, you will probably find him on YouTube with a very explanatory video, lots of cases, so very interesting to have a look at also after this course, and I think a lot of material is also in the course. The first lecture that George will give us is on colorectal ESD. So George, please, the floor is yours.
Good morning, everybody. So in ESD, the first step is to identify which is the ideal lesion to remove. And I still struggle to understand whether a lesion is invasive or not. This is where I personally suffer. The second step is to understand the strategy of resection. And this is the longest and toughest learning curve. Thanks God for you, nowadays, you have a lot of tools. In my days, back in 2015, when I started doing ESD, we didn't have knife with injection properties. We didn't have traction, okay? We didn't have tunnels, so it was very tough. Now, you have all the tools to accelerate in your learning curve, okay? So try to understand the strategy for each scenario. I will start with the first lecture on identifying which lesion is good for ESD, and then I will show you some animations to understand which strategy you will choose depending on the location and the lesion, okay? I may show you some impressive cases, but these were done in the last 3 years. I have done a lot of perforations, many failures. I have done procedures for 12 hours, okay? So you will see the best, but this is not the reality, okay? So let's start. Perfect.
How about the light? Maybe we should dim the light a little.
Yes. So do you recognize some strategies here? So I'm a big fan of clip and band ESD. I do almost every case with clip and band ESD everywhere in the GI tract, esophagus, stomach, colon, rectum. And this is the other principle, tunneling, which is very nice in the rectum, particularly in the esophagus, actually everywhere, except maybe in the stomach. And for each technique, there is an application and a combination too. So which lesion is suitable for ESD? Do you want my opinion? Every lesion. Okay, so let's see what the guidelines say. We have the 2022 guidelines that say that ideally rectal lesions more than 2 centimeters are good for ESD, or lesions that have signs of early submucosal invasion. And then we have an update, and what they say is that rectal lesions more than 2 centimeters, especially those with a big nodule, it's better to remove them by ESD because there is a high probability of invasive cancer. Or a lesion independent of location, if you have the skills to avoid perforation, if you suspect early invasion. So, practically, rectal lesions bigger than 2 centimeters are excellent to start. Pay attention that the rectum has 3 portions, lower, middle, and upper rectum. And despite the fact that rectal ESD is safe, sometimes you are very close to the peritoneal cavity and you don't know it. So you do a perforation, you say, no, it's no problem, but actually you are in the peritoneum. So some patients have a very short rectum. You can ask your radiologist, if he's very strong, to identify the location of the lesion in the rectum and understand if there is intraperitoneal portion. Okay, this is very important in case of perforation. Otherwise, if you do perforation in the lower rectum, it's no issue, no problem. This is the ideal lesion for ESD. Why? Would you like to comment? Yes.
It's very flat, so there's a higher risk of invasion. I cannot see the MDI pattern.
Do you know the Paris classification?
Yes.
What is the Paris classification of this lesion?
Spreading tumor, non-granular elevated.
Non-granular. So that's the key. This is a non-granular lesion. What does this mean? Anyone knows what is non-granular? Non-granular means flat, no nodules. This is the first sign of probable high-grade dysplasia or even invasive cancer. But there is one more sign here. What's the second sign of probable invasion or fibrosis?
I don't know if the lesion is folded or not, but the middle is depressed.
Exactly. So this is the second sign you have to identify. We have a central depression. If you have a central depression, you should do underwater inspection with the best endoscope you have. And I work with Olympus and Fuji. If you have an Olympus, which instrument from Olympus has the best camera? To identify the microvascularity and do the JNet classification. This is very important, guys, to know the tools, okay? Which endoscope from Olympus is the best for study of the microarchitecture? Which model?
Excel series.
Yes. Which model from X1 series?
1500.
Yes. So 1500. This is the best endoscope, the gastroscope, to do the new generation of dual focus and analyze the structure. Which one from Fuji?
The newest one.
Huh?
The newest one. They now launched the 800.
Which one?
800. I think they launched the 800 series nowadays.
The only zoom nowadays is the 760. 760. Maybe they will make a new zoom endoscope. But the 760 has the best camera to study the microarchitecture. So, another message. You have to know which tools do we possess to analyze the lesions. So when you go back to your hospital, try to see which endoscope has the best camera. Okay? And now I will talk to you about the mountain of stupidity. Do you know the mountain of stupidity? Okay, does any one of you is the only one who does ESD in his hospital? You? Okay. Me too, back in 2015. Okay. So I was proud that I was the first and the only one who did ESD, and the second one in Greece at that time. And I had experience of 10 cases. I was very proud of myself. I felt very strong. But unfortunately, in the private sector where I work, the learning curve is not normal. It's not regular. I have one day a case in the stomach, the next day is a case in the cecum, and the next day a case in the esophagus. This is not correct, I mean from a didactic point of view. So we had to handle this case, non-granular lesion, that means high suspicion of fibrosis, central depression, and some additional difficulties. This was at the flexor, rectal sigmoid flexor, and this area had received radiation therapy. Okay, so I was ignorant of my capabilities, and I was very proud. I did a tunnel. Here you have a pocket. I did excellent work until here. And then I did, as in the books, a very good pocket. And then I did, what did I do?
Perforation.
Perforation. This is a perforation. Actually, this part is the muscle layer from the other side of the bowel. So this is a huge hole. I close it. And this is another topic and would be another lecture. What do we do after perforation? I will be very fast in 1 minute. In that case, you close it as fast as you can. The preparation should be always perfect in ESD. And what I do next is a CT scan with contrast from the anus. Why? I want to confirm that I have no leak, that my perforation is completely sealed. In that case, maybe the patient will experience this perforation as a diverticulitis with only antibiotics. But if the patient develops peritonitis and you have proven that the bowel is completely sealed, what are you going to do? Are you going to do colostomy? Probably yes, that's what the surgeon will tell you, but don't allow him. He has to do just laparoscopy, okay? Wash the abdomen with saline, aspirate stools, inflammatory liquids, and just place a drain. After 3 days, the patient will be okay. So no need for major surgery. So this is another principle that is not taught in ESD lectures, and you learn it in the hard way. So in case of perforation, first you confirm with a CT scan with contrast, not from the mouth, from the rectum, okay? You can put contrast into a water pump, press the pedal, full the entire bowel with contrast, same thing for scan. Don't worry about the air, okay? Air is a friend. Actually, it's not air, it's CO2. I hope so. No? Okay. That's not an issue. You can even puncture it. And if you have sealed the perforation, just give antibiotics and wait to see if the patient will become septic. If the patient becomes septic, you wash the peritoneal cavity with laparoscopy, drain, and it's done. This patient developed peritonitis, but she had laparoscopy 3 days later, she was at home. Okay, so no major. And I was telling that this is I have reached the top of the mountain of stupidity. I felt more confident than I should. So if you do ESD, please stay humble. Okay, after every success, every big success, there is a failure that will follow, because there is a huge variety of cases, and you cannot always be confident that every case will be normal, okay, and easy. So be humble and try to deal well with the complications.
Could you remove the lesion?
Yes, the lesion was removed unblocked, and it was actually early cancer. The patient had a very good prognosis. 5 years later, she was okay. So here there is, this is a good indication for ESD, but it's a tough one, but it's feasible. Huge lesion in the rectum with involvement of the anus. So when we start ESD, we're afraid of the anus. Don't worry, the vessels are not big. The bleeding is not like a jet. It's oozing from veins. In that area, I like to use spray coagulation. I'm very aggressive with spray coagulation, 3.0 via 3, okay? And I'm very aggressive and no problem with the anus. But if you use strong current in the anus, you may have another problem. What's the problem?
Pain.
Pain. Pain. So if you do a lot of coagulation in the anus, the patient may experience pain even for 1 month. Okay? And in the rectum, we always give antibiotics. So this lesion, despite the fact that involved the anus and the rectum, was removed and blocked.
You give antibiotics, you said.
So I always give antibiotics in ESD, but based on the guidelines from ESG, lesions from the rectum, even if they are removed by EMR, need antibiotics. Why? Because some experts experienced cases of endocarditis after rectal ESD, and now, without strong evidence, we give antibiotics during each procedure of rectal EMR or ESD, which takes a long time.
But just one single shot, or you?
I give for 5 days, but the recommendations are loose. They say just at the time of the procedure. But I give for 5 days
And what do you
in the rectum. I give broad spectrum antibiotics, amoxicillin, augmentin. Another good indication for ESD in the rectum is case. You have a question?
Yes.
Yes, please.
When the lesion involves an anal canal,
Yes.
do you use ropivacaine a little bit in your
Good question. Yes. Yes. You can add to the liquid anesthetic. Yes. So the mixer. Currently, I don't use injection needles. I use just my knife. So I'm a big fan of flash knife by Footsuit. So what I do, I use normal saline, 500 milliliters. I put 1 or 2 milliliters of indigo carmine, 1 milligram of adrenaline, and if you are in the anus or rectum, 2 milliliters of lidocaine. Okay? Yes, please. So, in case of fibrosis, we are very good in dissecting the fibrotic part, and this is a big advantage for areas where you have a nodule here, another nodule here, another nodule there, so you remove the entire area and block. But you may use perforation. If you are in the lower rectum, it's not an issue. And you can do it even in cases of recurrence deeper if you are more experienced. For example, this is an extreme case of residual adenoma after multiple EMR that involves the anal canal and the rectum. The best way to identify the areas of recurrence is to use underwater inspection with MBI, or here you see an area of fibrosis. I prefer to put some marking around the lesion because after a while everything becomes very blurry. This is click sign mode. But the best way is underwater with MBI, because here you can delineate very well where the recurrence starts here, for example. Okay? And in cases of the anal canal, I start with the difficult part, which is to delineate the part of the anus into a pocket. And then I move forward to the rest. And this is, in that extreme case, the final image of circumferential ESD of the anus or rectum after a recurrence. Obviously, this patient will develop stricture and will need self-dilations. So I ask the patient to do self-dilations with their finger or even with an external device. And sometimes we become very kinky with this device. Okay? But this is this can save the rectum and the anus in some cases, despite the fact that they will have many dilations later.
How long was the procedure?
The other procedures, I think, I'll be honest, I don't remember. Between, let's say, about 3 hours. 2.5, I said. Okay, so this is another case. So this patient was referred by a gastroenterologist who did EMR in the sigmoid colon, and he said, I have a small recurrence with high-grade dysplasia. Can you remove it? To be honest, nowadays I would do Vesco for that case. There is no reason to struggle with a very copious and risky ESD. You expect a lot of fibrosis, the area is prone to perforation. You have to be practical. Now, I did ESD, but retrospectively it was not a good decision. Now, what do you see here? So here we have underwater MBI inspection. Anyone wants, please, the Barrett expert. What do you see here?
Well, I see a bit of a depression.
What is the JNet classification of that lesion? Do you know JNet classification?
Oh yes, but I always use my little...
I do also.
Yeah.
Okay.
Printed version.
Yes. So here you have loss of what?
You have you have loss of the regular pattern that's surrounded
of the microarchitecture. And when we comment the microarchitecture, we study two things. What are these two things? Please tell me.
Vessels and the paper.
Yes. So here we don't recognize the vessels, like we recognize maybe here, and we lose this. The surface and the villi are completely destroyed. So here we have cancer, guys. So here we expect invasion. And what is the size of the lesion? You. Huh?
About the gap.
Yes.
9 millimeters. 10 millimeters.
Exactly. So that's an important information, because that means that if you use a Vesco, you can remove it. Okay. But I was very confident. Mountain of stupidity. I marked the area, and in that case, we need two additional tools. You need a knife that is very sharp and can hook precisely the fibrotic tissue, and you need traction. Without traction, this is a nightmare. And traction in that case can be achieved with clip and band easily. Here you see the strong attachment of the lesion to the wall. Question, you. Why do we have, this is fibrosis or is it cancer?
Could be both.
That's the answer. So you're doing an ESD and you see that you're not able to touch the lesion here. So let's suppose you are in the sigmoid colon. What are you going to do? We are in the sigmoid colon.
You got the answer. If you're not able to do it, then I think it needs operation.
Yes, you may stop, you may pray, huh? Or you need, you are very confident and you did what I did, or you, yes. Now, if you are in the rectum, what do you do if you are in the rectum? You are in the lower rectum and you have this image. What do you do?
Go for it.
Sorry?
Attempt ESD.
Yes, but you do a modification of ESD. What's that? I may have to show you tomorrow a video about that. You go deep. So in the Netherlands, you're very good at that. Tell me, what do you mean you go deep?
We go intramuscular.
Intramuscular. Okay, so if you're in the rectum and you have this scenario, you go intramuscular or even what?
Transmural.
Transmural. Okay, so you don't do that in the sigmoid. Okay, but if you're in the lower rectum, you dissect here either between the muscle layers or you do transmural resection. Finally, this lesion was removed and blocked, but it was a T1 SM2, so more than 1,000 micrometers of invasion. The patient was young, so she had surgery.
So can I ask, for this case, what did you do
So,
to get through the fibrosis?
sorry?
To get through that fibrotic
Yes.
or attacked area?
I used hook knife
Yeah.
and traction.
But so you saw that middle picture there?
Yes, actually I cut through the fibrosis, but actually I was cutting through the cancer. The cancer touched the deepest margin.
Can I ask you a question?
Yes.
I mean, there's also a huge discussion at the tumor board. When should they have surgery or not?
Yes. So the guidelines say that if you have an invasion, there are some criteria, histologic criteria.
Yeah.
Who knows the histologic criteria? Tell me.
So the lymphatic invasion.
No lymph invasion.
Yeah.
What else?
The grading.
The grading. Yes. So what's the acceptable grading?
The more important is like the depth.
So we need moderate or
Yeah.
good differentiation or moderate.
Yeah.
No lymphovascular invasion. No vascular invasion. And in terms of depth, how deep? 1,000 micrometers. Okay. And sorry. Yes, tumor budding, of course. Yes, low tumor budding. And that's it. Now, if you go beyond these characteristics, you should discuss in a multidisciplinary session. If the patient is very old, maybe he will receive radiotherapy or chemotherapy for the rectum. For the sigmoid colon, it's a tough question.
I'm sorry for that. In Germany, the guidelines will change.
Ah.
Now, I think it come out in 2 months.
Yes.
And there's no the deep invasion
Yes.
is not a criteria anymore.
Exactly.
So if you have SM3, it depends on the differentiation.
Yes.
It depends on the lymphovascular pattern.
Yes.
And also the tumor budding is in the guidelines to show only it can be a risk factor, but it has to be discussed in the tumor board. But the criteria of the deep invasion is not anymore a debate.
That's why in the lower rectum, if I understand there is invasion, I do full thickness resection in order to achieve area-0 resection. Because if you go just intramuscular, you have a very short free margin. Okay, and this is a factor of recurrence. So this lesion is again suspicious for neoplasia because we have depression, loss of vascularity. This is also a very good indication for ESD, even if this lesion is a pedunculated polyp. One more case of a big rectal lesion.
When you classify a polyp with JNet3, do you still perform ESD?
For JNet3?
Yeah.
For JNet3, I rarely do ESD except if the patient is very old, the lesion is at the rectum, especially at the lower rectum, and if he doesn't want to undergo surgery. Okay. Yes. I will show one case like that. So this is one more case of big lesion. The difficulty is that many times, we are not able, I am not able, to predict exactly if the lesion is borderline for resection. So this was SM2, and for that case, which is from 2019, I removed it, but the pathologist told me that, George, your deep margin is very close to the cancer. So that's embarrassing. And I mean, it's not my fault, but you don't know what to do with the patient. So for an old patient, adjuvant radiotherapy is a good option. And this case proves that, because this patient is still alive, he received radiotherapy, and with follow-up up now, no recurrence. But I have one identical case with recurrence. But that patient did not want to undergo to radiotherapy. I don't know if radiotherapy would save him, but it seems that it can be helpful. Now for a young patient, 50-year-old, I'm not sure if I would suggest radiotherapy or radical surgery. It's a big discussion. One more case, and this is a pedunculated lesion with JNET3. So even pedunculated lesions, it's better to remove them by ESD if you have signs of invasion. You want to have the deepest clean margin. One more similar case. And this is another case. So once you have reached a good level of expertise, you can remove benign lesions too, that are just big, but not malignant. So the indication on guidelines for these lesions is to remove them by EMR. This is a classic dentate adenoma of the serrated adenoma of the right colon, but maybe we'll see later. You can remove it with ESD once you have developed the appropriate skills. But EMR is acceptable, okay? Piecemeal EMR. And these are some more extreme cases. So in this video I will demonstrate you many techniques. So this is a big lesion at the ileocecal valve, and for that case you need many techniques. Okay, so we will use pocket, we will use clip and band traction, we will use a tapered tip cap, and we will use also multiple knives. So this is a microgranular adenoma at the ileocecal valve. These lesions are benign, but here we have invasion into the terminal ileum. So in that case, the borders are not very evident. We will use MBI, underwater, under saline inspection in order to identify the borders. This is, by the way, the dual knife. Now we are into the terminal ileum, and we identify the borders inside the terminal ileum. I know that most ESD experts don't do marking before colon ESD. I do it. Why? Because with adrenaline, with bleeding, after a while you may lose the borders, and it's very embarrassing for me during the procedure to see that I lost my orientation. So I think it's good to do a marking. And in ESD, I like to start from the difficult part, as we do in life. That's my philosophy. We do always first the difficult part, the toughest part. Here we start into the terminal ileum. In this way, we try to create a flap inside the terminal ileum, and here we use another knife, another fantastic tool. This knife has a ceramic tip, and you use it for lateral dissection, and you protect the muscular layer when you are very vertical, tangential to the muscle. And this is my favorite technique, slip and band traction. And actually Microtech has a device that does it without using dental bands. And here we have traction, we have a pocket, so we have many techniques at the same time. Here we have a good submucosal space. At the right is the mucosa, at the left is the muscular layer. And you know, if traction is not good, you can change it. For example, here we use additional traction. So we change the axis of traction during the procedure. I call this dynamic traction. You adapt to the procedure. This is another knife with a bold tip, which is more strong. And here we use one more technique, under saline dissection. Fantastic technique, because in case where you have poor lifting, you make the submucosal space to float. You need always a co-grasper for large vessels. You grasp and you pull back in order to avoid deep muscular injury and late perforation. And once you're done, you cut the last mucosal bridge. And this is a very nice device to cut the loops, the bands. This is called endoloop cutter. Okay, and this is the final image of the ileocecal valve and the sepals. So even big lesions that were assigned to Japanese can be done once you have enough experience. Okay, and now a hot topic that was raised mainly in the Netherlands is how do we deal with such lesions in the lower rectum. So normally this is not a lesion for us. Okay, we don't touch these lesions. Where do we touch them? I want to touch it. So in the setting of a patient who is very old, who is not an operative candidate, where the lesion is not huge, it's 2-3 centimeters, and if the lesion is at the lower rectum, we have shown even in the multi-center study that with an off-label application we can do this. So what's that? Guys, this is TEM by gastroenterologist. So you remove everything. You do transparietal resection in the lower rectum. This is the perirectal fat. This is perirectal fat. I know it looks very scary, but if you do it in the lower rectum, it's safe. And this is envelope resection of a T2 cancer. This lady had a 5-year negative follow-up without recurrence. She received radiotherapy. Okay. And why did we do that? Because she was 85 years old. She had bleeding from the tumor. So the question was not to save her from cancer, but to save her from persistent bleeding due to the take of anticoagulant therapy. So she had multiple hospitalizations due to bleeding. Her son was a surgeon, so with his consentment we did such an experimental procedure. But it seems that it may become the future in the next 10 years for very specific cases combined with radiotherapy.
Can I ask you something? Did you close the defect or did you just...
Good question. So no, I didn't close it. I could now, but I didn't close it. Why? Because there are studies made by surgeons who do TEM and TAMIs. They compared patients where they closed the defect versus patients where they didn't close the defect. Interestingly, there were more complications when they closed it. So you can leave it open, but you should be very certain you are below the peritoneal reflex. Okay? So
you cut through the muscle?
Yes.
Circle and
I will show you the video.
Okay.
So in conclusion, which cases are for ESD? Colorectal ESD. Non-granular lesions, anal rectal lesions more than 2 centimeters, recurrent polyps, T1A colorectal polyps, and here I think we will have major help from AI, because I don't feel that I have the knowledge, the Japanese knowledge, to identify with confidence this disease. Let's be honest, it's not easy. Once you have at least 100 cases of experience, I think you can launch into every polyp independent of location. Okay? And you saw also some experimental resections for rectal tumors. It's obvious that you will subscribe to my YouTube channel, okay? You have 1 minute to subscribe before I show you some fascinating videos, okay? So I showed you the theory, which lesions to treat, and now we're going to discuss about strategy. Okay?
May I ask questions?
Yes. Please.
What do you think about rectal cancer below 2 centimeters in the rectum? Do you do an FTRD or do you do ESD or ERD?
I never do FTRD in the rectum. I do FTRD in areas where perforation will be of high risk. So in the everything for every lesion about 1 centimeter proximal to the rectum. Yes, I will not launch an ESD. If the lesion does not enter into the cup, I will launch to an ESD in the operative theater with a surgeon near me, with the family and everyone informed that we're going to do a risky procedure. But if the lesion is less than 2 centimeters, I will prefer to do FTRD, yes.
In the colon, in the rectum?
Never in the rectum. I mean, it's only if we are close to the sigmoid colon. Okay? And the FDRD is not so safe. You may grasp an organ outside of the lumen. It's not so. So a few slides about the strategy. So you have heard about circumferential incision, pocket creation method, tunneling, clip and band ESD, under saline dissection. It's a mess. Okay? So I will try to show you how I think how I analyze a lesion. First, you do the Paris J-net classification, you estimate the borders. Then, guys, you check gravity. How do we check gravity? How do we check gravity?
Just insulate with water and see where the water goes.
All right. Do you like this?
No, I don't like it.
Why?
When it starts bleeding, the bleeding is also in your pocket or
very nice.
Area.
There is an exception. If you want to do under saline ESD, which is very good, you will work like this. But if you don't want to use under saline technique, you will change the gravity. Okay? So for classic ESD, you work like this. Lately, I don't care a lot about the gravity because I use all techniques in the same procedure. I'll show you. When we have a lesion at the rectum, you may start with anal incision, especially if the lesion invades the anus, and then you do the oral incision. And then you have several options. Usually you do a central pocket and you connect this incision with this incision. Now I will tell you a mistake that I still do even now. What's the mistake? You don't go deep when you do the incision. And that's a big embarrassing moment when you do tunneling and you say, where's the end? Where's the end? Especially in the stomach. So this incision is very crucial. You have to be sure that it's very deep, okay? Otherwise you will be tunneling forever. And these are the variations of my techniques. So once you have done that, you have two directions. You can do the classic pocket creation method like Dr. Yamamoto presented, okay? And use the gravity, or use traction during the pocket creation method. So you can use, depending on the size of the lesion and the location, different techniques. In addition, you may change between CO2 and water. Why do you use saline and not water? Anyone knows the answer?
Because of the electricity.
Yes. So, another message about your equipment. You should always use two pumps. One for the knife and one for your endoscope. I see many Japanese in some live workshops where I'm invited, they use only one pump for the endoscope and they have an assistant to flash their knife. I don't understand why. If you have a second pump, you are independent, you are faster, and you have a lot of pressure. You go faster.
May I ask a question?
Yes.
Because I noticed that when you use the pump, if there is sometimes air gets in the fluid, and then you pump air instead of fluid. It happens several times, and we tried everything, we tried to flush and everything. There still gets air in the fluid. So when you
Bubbles.
Bubbles. Yeah.
I think this is a question of how your water pump works.
Pressure. You say high pressure and there's turbulence. And there's bubbles.
So you have to
Lower the pressure.
lower.
You may change your device. IT knife. This is the unheard hero. You should always have an IT knife. For which scenario? When you are vertical to the muscle, in order to avoid perforations. I have regretted many times that, especially at the end of the procedure, I was bored, I didn't want to change knife or open a new knife. But no, if you're tangential, you don't have a good lifting, use an IT knife nano, to protect the muscle. Use hook knife when you have fibrosis, but this is a very dangerous tool. Okay, if you use it in the rectum, eventually in the stomach, but not the proximal stomach, the distal stomach. But in the stomach, to be honest, we don't have fibrosis. Okay, mostly it's on the colon. And now, time for movies. Okay, so yes.
Is there a reason that you start at the anal side or the oral side?
No.
No, it's.
I just, there is no, you can start as you want. So this is a small lesion, okay? But this lesion is very bad lesion. This lesion is better to remove by ESD, even if it's small. FDRT, yes. Now, we are in the ESD course.
Yeah.
Okay, so we have loss of the pattern microarchitecture at the center of the lesion. We have depression, so everything screams and says, oh, here we have a malignancy, probably. So even for this lesion, it's better to do ESD, and don't be a saint. That's another message from a self-taught person without any mentor near me, okay? I did small lesions too. I did easy cases too. We have to learn, guys. We don't have the ideal case every day. So don't be embarrassed to remove such a case with ESD, even if it takes you 1 hour. All right? So my technique, I put some marking, although it's not accepted by all experts. Okay, we put markings with forced coagulation or soft coagulation, low wattage. You don't press a lot, just tap. Okay, you keep a good margin distance from the lesion. And for the pocket creation method, you start either with the distal part or the oral part. The classic technique is with the distal part. Okay, we do an incision, and let's talk about settings. The classic setting is endocut, Q or I. I is more correct for knives. And look how I work. I work close to the mucosa at the beginning because I don't want to damage the muscle layer. This is a very important step when you start ESD. Don't go close to the muscle during the first incision. You work close to the mucosa and you do what we call trimming. So you do the initial incision and then you open up the space and you inject with your pedal again and again. I work parallel to the muscle. I don't work vertically, and I still work close to the mucosa at the beginning of the dissection. Okay, later I will go deeper. And then once you have created some space, you try to enter inside this pocket. Now, which current are you going to use here? My favorite current is endocut. It's very fast, very accurate, and you don't destroy the normal anatomy. You don't have the coagulation effect. But if you have vessels, it's better to use a coagulation current like swift coagulation, which is the most famous current, or forced coagulation, and especially if you have these tiny vessels, you approach them and you use the coagulation. If you are early in your experience, I don't recommend to use endocut for dissection because your dissection plane will become a mess with blood. It's better to use swift coagulation 3.0. This is RDI mode for identification of vessels. To be honest, I don't like it. I don't find it useful, okay? But I demonstrate. This is coag grasper. You saw the technique. We grasp the vessel and we pull back. We don't want to induce a perforation. And you press it for 2 seconds until you see some bubbles. And here we continue. In terms of movements, the movement is done with rotation of the shaft of the endoscope and up down. We don't use the small wheels, and never, there's no never, but try to avoid to use both your hands at the wheels. Here we use a spray coagulation or forced coagulation. Okay, and we have created a pocket, and now we will open the pocket at the cephal side. So we'll do an incision over the mucosa, and this will open.
It is important which kind of injection needle you use, or it doesn't matter?
No, I like a lot fine needles. My favorite needle is from Boston, but more and more I don't use needles anymore. I do a tap with my knife with endocut, and then I press the water pump and...
Even in the colon?
Yes, in the colon, try to avoid it, but when I'm bored, I do it. Didn't hear that, but I do it, especially under saline, because you're very safe.
Oh.
But yes, you can use whatever needle you want. Try to use a fine needle.
Okay.
And
precise sect.
Precise sect, yes. I don't use it, but I see many experts that they use it. I'm not the best person to talk to you about precise sect. I use endocut, dry cut, forced coagulation and spray coagulation. I use endocut for incision and dissection of avascular areas. I use dry cut instead of endocut when I have a juicy environment, like the rectum or the antrum, or the cardia, which is very juicy, the lower esophagus. And I use spray coagulation when I want to go fast in the rectum or in the stomach. And forced coagulation, I used it when I want to stop using spray coagulation and make a pause, because spray coagulation produces a lot of gas.
Yeah.
And the abdomen becomes bloated. So at the end of the procedure, you cut the bridge, and this was the pocket creation.
What was the reason you didn't use the clip-on band in this particular case, but you just said you always use it?
Why
didn't use the clip-on band technique in this particular case?
Okay, I used it in 90% of cases. This patient probably didn't have insurance, and I want to reduce the cost. Okay, I work in the private. It's not all. When you use the clip and band, you make safer the dissection and faster. So if the lesion is very easy, like this one, it's not obligatory to use it. Now, let's see another. Okay, this is an extreme case, but in this case, you will see all techniques. Okay, so here we have a huge serrated lesion at the right colon. In this case, you should always identify the borders, because they are not clear. Okay. So these are the borders. So the lesion goes beyond the fold. Actually, it expands between 2 folds. This is under saline dissection. So I use for this case pediatric scope, PCF 190. I use a tapered tip cap by Fuji, it's called SD Hood. This is flash knife. We work under saline because in this way the floating of the submucosal space protects you against perforation. And despite what is currently proposed, I do circumferential incision. Why do that? Because I've stolen this technique from the French guys in Lyon, Mathieu Pios. He does circumferential incision and then traction, and I like it for such lesions a lot. Once we have done circumferential incision, we use the first portion of clip and band, and in this way the dissection field becomes very clear. At this point, we have dissected the right part of the lesion, and now we move at the central part of the lesion where we don't have an ideal lifting. We have a lifting, but it can be even better. That's why I don't hesitate to use a second complex of clip and bands at the central part of the lesion. In this way, we achieve a very clear dissection plane, and the strong traction makes the dissection more effective. So when you press cut, you cut more fibers than you do without traction. That's how I perceive it.
And you don't damage the lesion then?
I work in the middle between the mucosa and the muscle. And I try to flush saline with my knife or with my saline pump in order to have a thick submucosal space. And when you work under saline, you use endocuts. Because this is the only current that works without what?
Air.
Without?
Air.
Bubbles. So it's when you work under saline, you produce bubbles with your current. The only current that does not produce bubbles is the endocut. Okay? If I have a vessel, I aspirate the gas, the water. I work under CO2 and I use spray quag. Although there are many videos and publications with coagulation under saline, but it doesn't work so well. So this one, maybe I'll show you this tomorrow. It's dissection of the entire ileocecal valve, and this is the case, the TEM case. So this is the lesion. Does it work? So this is the tumor of the lower rectum. It works. Okay. So this is the old lady. So for that case, we do full thickness dissection. And for that dissection, you need a knife with a long blade. So the ideal knife for that is a hook knife, or variations of that knife. So it's evident that this is an invasive cancer. I mean, if you don't understand that, you should abandon gastroenterology. We do the marking. I was very scary when I did that case. You see me now calm, but I was very scared. But I did that with the surgeon behind me and his approval. So here we do injection, and the first step is circumferential incision. I use a variation of what's the knife for poem? Triangle variation. Yes. So this is not a triangle knife; it's a square tip knife. Similar concept. And once we did the mucosal incision, we do the circumferential muscular incision. And this is the fat. Big vessels are encountered and myotomy is done with spray coagulation. This is the strongest current in order to deal with big vessels. So coag is a fantastic tool for coagulation, but if you have big vessels, an old-fashioned hot biopsy forceps is better. Okay, for big vessels. And this is the final inspection. So that was, I think maybe this is the future for these lesions. So with this video, I completed my talk about colorectal ESD. Would you like to do a break, or we'll continue?
I have some questions.
Okay.
But you did a CT scan beforehand for this lesion?
Of course, CT scan, US, MRI.
Okay.
Yes. Because if she had lymph nodes, we wouldn't attack this lesion.
How are we with time?
We're okay with time or not? We're okay. I'm on time.
Just in terms of strategy, and in some cases I've seen endoscopists deliberately leave a bridge of tissue to help.
This is a way of.
How do you select when that's going to be useful?
If you don't use traction, clip and band traction, you need some natural traction. Okay, so you make a bridge. So this is an old-fashioned way to do ESD without external devices. And what I have learned from Japanese is that I think they think that if they use traction, it's a compromise and it's something that shows that they're not very capable. I think that's the way they perceive it. I'm more practical. I want the job to be done safely and fast. So traction for me is a fantastic tool for that. But if you don't use traction, bridges, Dr. Koch will show you the bridge in the esophagus.
And
likes
of tissue bridges. So
yes.
Yeah, natural traction. Any other questions?
Can I just ask, this serrated lesion in the right colon, what was the benefit of removing it by ESD and not just piecemeal EMR, which would have been a 15-minute job perhaps?
Yes, you can do it by piecemeal EMR. You can, of course. This is what I would suggest to do it.
But what did you gain
by
doing it ESD?
Okay, because I wanted to remove the unblock. That's the Japanese answer. What do you want now?
There's not a lot of scientific evidence to support that. Unless you deal with an early cancer or suspicion of an early cancer.
When you have a lesion very close to the anal rectal border, do you do the first injection? Do you do it in the anal canal, or do you try to stay in the rectal mucosal area? How far can you go into the anal canal?
Anal canal is not the problem. You can go even at the exterior part, not an issue. And the only issue is when the patient has problems. When the patient has big hemorrhoids, you don't have very good stability.
So a low lesion should never be a reason not to remove?
No, this is a fantastic indication for ESD because every other technique has compromises, especially the surgical techniques. They cannot see the borders very well, and they may damage also the sphincter.
For the knife, do you use a normal water pump?
Yes,
Yeah.
yes, a conventional water pump with normal saline.
Depends, of course, on the type of knife you're using. But for most knives, you can use the standard water pump. All right, thank you, George. And then we'll have a second presentation later on.